Hello and good afternoon to the latest in our series of webinars, and thank you very much for joining us today. We're delighted to have two speakers from the Somerset Shared Care Record team to speak to you. Our speakers today are Jess Brown, the Digital Transformation Officer, and Dr. Justin Harrington, who's the Chief Clinical Information Officer. We also have Tiff Hodkinson, the Chief Operating Officer at Black Pear Software. Black Pear specialise in clinical system interoperability, and she'll be answering any of your technical questions. They'll talk through the unique setup of the SIDeR Shared Care Record that uses FAR endpoints to gather and display real-time information for including social care for the purposes of direct care. There are also a suite of shared forms and care plans on SIDeR that can be created, updated or viewed by appropriate professionals involved in that person's care, and a link to the GP records and EMIS. As I said, the session is now being recorded, and we'll put the recording on our YouTube channel in due course. We've kept you on mute, but do pose comments or questions on the chat page, and we'll come to those after the presentation. My Wessex Care Records colleague Paul will be monitoring this during the session. And so that's enough from me, and I'm very happy now to pass over to Jess.
Hi, I'm Jess Brown. I'm Digital Programme Officer at NHS Somerset ICB, and I've been project support for the SIDeR programme since its conception, which was many years ago. And I'm now the interim lead for the active programme. I'm joined by Dr. Justin Harrington, who's been the clinical lead for the programme as well since the beginning, and we've also got Tiff from Black Pear in the audience to help us answer any technical questions at the end, should we get any. So what is SIDeR? So as I said, it's been a concept for many years. It finally came into fruition with a first contract being awarded to Black Pear as our current technology partner in 2018. It's a clinically led and digitally enabled programme that aims to make the right information available to the right professional at the right time. So it's for direct patient care, not for any other reason. It's for use across health and care settings, and the aim is to help reduce the number of phone calls across the system and make it much easier to find the information in order to provide the right treatment first time. The first SIDeR service, the Electronic Palliative and Care Coordination System, aka EPACS, went live in April 28, 2019. And it was the first use case due to a clinical need to have a single version of the truth for end-of-life patients that could be read, updated and created by all involved in their care. And then following this, the main part of SIDeR, which is the SIDeR Shared Care Record, went live in November 2020. I'm just quite keen to say that the SIDeR programme is much broader than just the Shared Care Record. It is about information sharing for direct care across all systems and can be used as a real enabler for issues within the system, and to help have interoperability and integration between systems. And as well as the Shared Care Record, we also have a suite of read, write and create shared forms or care plans that are designed to be that single version of the truth. So following that electronic palliative and care coordination model that went live in 2019. So the SIDeR Shared Care Record itself it's a succinct real-time data set. It's not persisted anywhere, so we don't use a data warehouse like other models. It's not meant to be fully comprehensive of all the information that's in the systems. It's meant to be the key information that would be important for a wide range of health and care professionals to see about someone. We don't want people to get lost in so much information that's very specialist. So it's developed by a group of clinicians to be useful to as many people as possible without getting too granular, basically. As I keep saying, it is for direct care purposes only at this point when someone needs care, not for any other reason. It's for use by all health and care professionals across the system, and there's no licenses required. Each organisation governs who can access, how they access, and that's linked to their clinical roles in their Active Directory. it's always been clinically led. We always want to go where the clinical need and the impetus is. So we aim to digitally enable anything that is of clinical need. We don't try and impose things. We want it to be as user friendly at the front end as possible. It's shaped by input from staff across the systems and also the public. We have been out to the public via Your Somerset. We took a leaf out of DCR's book for that, really, because they had have a very comprehensive communications model. So we do steal some of their ideas sometimes. And we have a Digital People's Champions group, which is attended by lay members, and we've been out via Your Somerset, which is a Somerset County Council newspaper across the county. And we've also done some surveys about understanding of information sharing. And SIDeR's the shared care record is flexible. So while it is a succinct data set, we're happy for it to take on new use cases and look at expanding the information that's in there. So while no information is retained, it obviously has an active audit log, and the information governance lead across the organisations has access to this, so we can monitor use and appropriateness. And so that is the shared care record in a nutshell, and Justin will be doing a demonstration of it later. The organisations that have connected their records to the SIDeR programme so far are Yeovil Hospital, Somerset NHS Foundation Trust, so that's the acute Musgrove Park Hospital, and also community and mental health settings that used to be Somerset Partnership. Somerset County Council Adult Social Care Services, and we're very close to going live with children's social care and education data, hopefully being signed off in October. St Margaret's have been a key stakeholder from the beginning. They've been on board since it started, as have County Council, and that's been quite unique to SIDeR, really having social care involved as one of the stakeholders from inception. And then we've got 63 of the 64 GP practices are connected as well. And we're quite lucky because our whole estate's on EMIS, so it's only one clinical system rather than having several. And the digital shared forms that I was talking about, that are the only parts of SIDeR that can be edited and updated, and that data is retained on so far. So we've got the end of life, which is the EPACs that I spoke about earlier. We've got special patient notes, or basic notes, which are notes to be able to convey messages to out-of-hours services about a patient. We've got advanced care plan. That's updated and created primarily by Marie Curie, who have been commissioned by the ICB to do that service. We've got 3 open mental health service forms. They're owned and governed by Somerset Foundation Trust. So we've got one that's a referral form from the GP. We've got one that's a Dialogue Plus, which is essentially a care plan, and then an update form back to the GP. We've also got the comprehensive assessment form, the latest one that went live on the 1st of September. And as part of the pilot, we were exploring access for care homes because they are key organisations involved in that kind of work. And we're working to roll that out to them all as well. Eventually, it's just getting them connected to HSCN, because you need HSCN connectivity to connect to SIDeR at this point. We've also underpinned by a governance structure. So we've got an overarching digital delivery board, which is the highest level involving all stakeholders across the ICS. We've got our clinical leadership group, and that includes consideration of clinical safety aspects, and any initial ideas will go through them to make sure that it's clinically needed and clinically viable. We've also got an assurance group from a contractual perspective, and an information governance group, because our IG model is quite unique inside it, because we don't persist any of the data. We don't pull all the data into a warehouse or anything and then take from there. So it's actually quite an information governance light model, and it's also based on, because it's for direct care purposes, it's informed consent based rather than actual consent. So some of the more technical key functionalities of SIDeR which stand out really is the ability to draw and send structured data to and from the GP record. So for our shared care plans, any demographic and appropriate coded medical information will be auto-populated into the shared forms so that it doesn't need to be input. It will automatically pull from the GP record, and every time it's opened, it will repull. So if there's been any changes, those changes will be real-time updated in the form. We've done a lot of development work with local stakeholders to create FHIR resources in order to pull data from their clinical systems. So all the organisations have got FHIR endpoints, and that's how we get that information from their systems into SIDeR, and we present it in one place. One of the other projects that's going on at the moment is looking at bidirectional information flow to other systems, i.e. Rio. So I know that the Dialogue Plus Community Mental Health Service form goes back to Rio. So that's the system used by Somerset Foundation Trust community. And we're working on sending information back to the Somerset FT, the acute EPRO as well. So that's quite early days, and our next step to be able to send information back into records. And Blackpear is our technical partner. Our technology partner. We're very keen to say that they're our partner rather than our supplier, because they're always coming to us with ideas, and their aim is to create an ecosystem in order to integrate with other providers rather than just creating new versions of things. It's about connecting what's already in place. And there's a number of benefits to that, which Justin will go through later. I'm happy to take any questions later on about any of this. So now I'm going to hand over to Justin, who's going to give us a demo of the test system as it stands.
Okay, thank you very much, Jess. So yes, for those who've joined us a little bit later, I'm Justin Harrington, GP by background and CCIO at Somerset ICB. I've been with this project since its inception, and actually we've been trying to get something going clinically for probably the best part of 10 years or so. So I'm just going to give a demonstration. And you should be able to see the record here of an individual. We wanted to use some test patient data, but we felt that there would be problems in terms of the clinical validation if we just used sort of false information that was loaded into a record, because often it's quite nonsensical or repetitive and doesn't represent the real world. So we actually got IG permissions to access the records of deceased patients, change their demographic details to anonymize them, and to present them through the system. So actually the records, these are the real entries, if you like, of a patient. And I'm saying that because obviously at the top of the page we have here the demographic details, but you will see underneath that this patient is deceased. At the top we have, as I say, their demographic details, but underneath this you can see that we have various tabs. So it opens by default at the summary page, which contains feeds around the active medications, as I hope you can see, allergies, encounters, problems and procedures from all the different organisations. Hopefully it will be evident from what you can see that these are colour coded to correspond to the tabs at the top of the page. So these orange yellow ones correspond to the fact that it's come through from the GP record, but equally there are entries here from St Margaret's Hospice and from the Community Trust in their various different colours. So this presents a summary, as I've said, and It's possible to also look at the encounters, which is something that clinicians felt would be useful to understand across a timeline. And if more information is required, it's possible to drill into these. If we look across the various tabs, alerts is fairly self-explanatory. And obviously some of the systems, such as the Somerset County Council, doesn't share flags, or they don't have any clinical flags or alerts. But it's possible to see from these records here that we've got entries that the patient is for attempted CPR and that there is a record of learning disability. Jess mentioned that some of the first products that we introduced were the shared forms, and these are stored as in their own tab. So we have the various items. We've got the end of life palliative care records at the top, but we also have the ability to include what we would call basic notes, which are sometimes useful for out of hours. It may not be clinical information, but it may be information about access to the property, that there's key safe, or there's a dog that can bite. That's the sort of information that is often sent through to ambulance services and to the out of hours providers. Jess mentioned that there's advanced care plans being done, created by Marie Curie, and as you can see, this is greyed out, so there isn't a relevant record for this individual. There's also been some additions to the patient's original record for demonstration purposes. So there is a first contact form here for community mental services, but no dialogue plus, which is the care plan. And there's also the comprehensive assessment form, which perhaps we didn't explain. This is a form that's been created to support the PCN-DES around care homes and MDT assessments. It's based on the geriatric assessment form, and that's been made live just recently in the beginning of this month in September. We also have the GP record, and as probably the richest source of data, this is something that people have been keen to see. What we have been using up until this point, that the record went live, was EMIS Viewer, and that has set the standard because people have found it useful to see the free text and the documents. This was the feedback that we've got through our clinical group when we've gone out and consulted with clinicians in the field, as it were. What do they find most useful in community services, in A&E departments, on the wards, in the middle of the night? It's to be able to see that detail. So we've done a lot of work with Black Pear about not only presenting the coded information, as you can see here, but also some of the free text. So it's possible to get information to feed through from some of the forms that we've created, and also some of the free text. So this is an example of something that would have been written in the GP record and is presented in format to the clinicians at their in their clinical role. And when we first presented this, it was felt that actually this would overload clinicians who weren't used to seeing as much information as GPs are in the EMIS record. So we've deliberately created this so it's it's nested, or it's if you like it, an accordion process, and it drops down more information. This here that I'm looking at is an example of the information that would be captured from an EPACS record. When somebody fills out one of those shared care records, that information can be coded information and text can be written back into the GP record. So, in effect, we're actually sort of closing the loop here. Having had filled out the EPACS record, that's gone back into the GP record, and then it's being pulled out and presented here as an example of what can be captured from some of the forms and how it can be presented. We've also got some feeds through from the county council, so there is some basic information presented here, but as I say, not all of this is available from every one of the stakeholder systems, because the patient won't necessarily have had contact with each and every one of them. But in pink, we have Yeovil District Hospital, and we have the information that's presented there. And you can see that this individual was under the care of general medicine, audiology, SFT is a combination of what was community and mental health and the Musgrave Park acute unit now. So we've separated those out, but those can be seen again in this picture here. But that's the acute services, and this is the information from St Margaret's Hospice. So I'll also demonstrate that we have some contextual launch. So we have here a synthetic patient, and this is what the patient's record would look like in the EMIS system that we have. And we've created, with the help of Black Pear, working very closely with EMIS, a contextual launch for GPs. We know that contextual launch is key to this system. There we are. As ever, the technology has its little glitches. So this is the EMIS GP record, and if we click on this link here, it will allow us to launch the Black Pear core record, as it's been termed. So initially, we've given the GPs access to all the shared care forms. We still need to do some work with getting the endpoints mapped for Somerset Foundation Trust acute unit, so that they can see the full SIDeR record from their own system. However, we are mindful that at the moment, GPs often have most of the information that's being presented through SIDeR in terms of discharge summaries and communications anyway. But it's felt that this will entice them to have a look at the system, as it's a faster way of them accessing all these various forms that they may well be involved in filling out and submitting in terms of the patient's holistic care. So I'm going to just stop presenting. I'm mindful of time.
Justin, do you want to carry on with the slides, or do you want to ask questions now, or should we do questions at the end?
Should we just go through with the slides and then pick up questions at the end? So we feel that the clinical benefits of this are likely to be fairly self-evident. It provides visibility of records for clinicians from multiple settings in one place. For the majority of users, they'll have access from their own native clinical system, and that increases the usability. That will save time for clinical and care teams in terms of accessing information. There's a lot of traffic that would have gone between other care settings and GPs inquiring about information, or from GPs to the hospital inquiring about some of the discharge details or care details from for a patient who's been in hospital. Patients spend less time repeating their information. It helps with integrated patient care, which is increasingly what we're looking to achieve when we think of ourselves as systems. And it gives the possibility of one version of the truth. It also allows teams continuity of their internal processes, and we feel it will enhance multidisciplinary working across organisational boundaries. And certainly we've seen some evidence of that when talking to people about MDT work. In terms of what's next, we're not happy with what we've got at the moment. We're looking to pilot and launch some more shared forms. People may be aware that PRSB have published standards about personal care and support plans, and there's an aspiration for that to be in the GP DESs. So we're piloting, we've built a personal care and support plan, and that's being piloted with one of our PCNs, with another one to be added, and effectively, once we know that that meets the requirements of the PCNs, we'll be rolling that out across our system. Jess mentioned that the children's data is in UAT, and it has actually completed that. So we're anticipating it's going to be presented to our next clinical leadership group in October. And if all is well with that, which we imagine that it will be, then that will be signed off and children's information will be live on the system. As we mentioned, it's context launch only into care plans for the GP practices, but we're hoping to do the technical work with Somerset FT so that we can give them full contextual access to the entire suite. We're also thinking about patient access to care plans, particularly the About Me section of the PCSP, and we're working with Black Pear to see what can be done via the NHS app, and that would be likely to be the first step in enabling access for patients to some of these shared forms. We're also looking to develop quickfire technology to create a bi-directional flow of information around medications. Somerset FT are doing some piloting work with NHS Digital around this as a concept. We're also looking at connecting continuing healthcare into user acceptance testing, because there's a lot of benefit for their teams to looking at this. We're also trying to get out of hours to be connected. Our GP out of hours supplier is trying to get their system to connect, but to be honest, it would appear that Adastra's roadmap is full until next development year. So that's rather disappointing, but we're trying to find technical ways to get round that and have a quicker launch that may not be quite contextual from their own native Adastra system. And then moving on, we're also looking to develop the ability to present some of the primary care documents. As I said earlier, that's something that clinicians in secondary care are keen to see. So we're getting some work scoped by Black Pear, and we hope to have a report on that in October to understand exactly how we'll be able to proceed with that. Community pharmacies are being piloted with them having access. We've also done some work with the Better group to understand how we can use a contextual launch from their system for people working in the acute teams at SFT. We're also keen to share some of our records with the Ambulance Trust, and Black Pear have done some technical work to connect to the National Record Locator Service, and we've developed some EPACS forms for a synthetic patient, and we're ready to test that. And we think that may be a way of connecting through to the whole system. We're also keen to do some work with Dorset GP records and Bristol Connecting Care. And we're also trying to get an understanding and collate the benefits that we think are there, and to actually get some data about that for this first SIDeR contract period, which is coming to a close in April 23. Black Pear are also doing some work with NHS Digital to become accredited, so that some of the documents which come through as care plans and are in the patient record come into the workflow, as that gives better visibility for GPs. So still a lot of work to be done. We think that there's a lot more that we could improve with all this work that we're looking at. And I think that's probably a summary of everything that we're doing and hope to do. So I'm aware of time, but it's been a bit rushed. We've tried to get it all done in half an hour, but there may be a lot of questions that people have got.
Brilliant. Thank you so much, Jess and Justin. Sort of a real tour de force over the last half hour. And I know there's a lot of questions in the chat box, some of which Jess has already managed to answer, which have been fantastic. Paul, do you want to lead off in terms of the questions being asked? I think Ian had a couple. I think one might have been answered, but
yeah, I'll start from newest ones, because Jess has managed to answer a few. So rather than try and spot which ones have been answered, I'll work backwards. So we've got Paul Stapleton's asked, apart from time saving, the benefits listed are capabilities or outcomes. He said, I'd be interested to learn about the impact of the Shared Care Record. I don't know if you can see the chat, Justin and Jess.
Yes, yeah, we can see the chat, and that's some of the work that we're currently looking at the moment, and that work has been delayed. When we originally went out to procurement, we used GP ETTF funding for this, and the money that we got, some of the money that we got was top sliced to look at benefits by NHS Digital and an NHSE, but that work never materialised. So I have to try and be diplomatic and say that we've taken that back in-house, and so we've only just got to work on that, and so it will be something that we would hope to have more information on in due course.
Okay, that's great, thanks. Next one we've got from Nick Hopkinson. Says, can you tell us about the steps you've taken to encourage use in different health and care settings, and where are current usage levels against what you would like to see them?
Yeah, that's a good question, and this has very much been a collaborative piece of work. I should emphasise that those stakeholders have been key in driving this forward. It's not just been Somerset CCG as was and Black Pear. It's been all those stakeholders, and they've contributed to a lot of the technical work and the clinical input. And the approach that we've taken is asking for those teams to share that within their own organisations. and that hasn't been quite as successful as we would like. So that is again a piece of work that we're looking at. But now we've got what we feel is a really useful set of information coming through. How do we go out and re-engage with the clinical teams and publicise this? Certainly we're looking at it being a standard part of the induction programme, for example, for junior doctors at some of the acute trusts. As I hinted at earlier, once we've got the contextual launch for GPs, we'll be going out and talking to them, because again we've got the information from social care which they don't have access to very easily currently. So there's continuing work to be done. I would personally go large, if you like, and I would say I think we could be achieving levels of usage 10 times that. But I think that some of these examples, for example, there's 124 comprehensive assessment forms, which are the, as I said, the MDT forms that have formed part of the PCN DES requirements. That's in just a month. So there are areas that we could do better, but equally I think there are areas where we've actually delivered quite a lot. We have those 6,000 mental health dialogue plus forms, which are the care plans, if you remember, that Jess was talking about. So that is actually pretty significant.
Okay, that's great. Thanks, Justin. Ian Haywood has asked about the interface wise. Is it EMIS CRV for real time, and is it IM1 for right back? Can you confirm that? And he's also asked. Sorry.
Yeah, I've turned on Tiff's microphone.
Yeah. Yeah, I would
Tiff,
defer immediately to the technical teams on that. That's well beyond my level of expertise.
No problem. Yeah, and he also asked, is there a plan intention to move to GB Connect? So
hi there. I've actually got Dunmail Hodkinson here as well, who's our CTO, and he's actually, I'm going to refer that one across to him.
It's like phone a friend, this, isn't it? So the answer is that it actually uses IM1 for both read and write, because it's was an existing technology that was available. There is consideration about moving to GP Connect, but it doesn't provide the same level of capability. But what it would do is solve the problem of how to access information for the cohort of patients who are coming in from outside the region, so they're not in one of the connected GP practices.
That's great, thank you. We'll move on. So I've got Ian Fraser, who has asked, can multiple users access and update records simultaneously?
No, they
Yes.
can't.
No, they can't. Okay, sorry.
Yes, they can.
I go to the technical people.
So it's multi-user access to records isn't a problem. You can have multiple users trying to update the same record at the same time. It uses optimistic concurrency. So effectively, you've got a race to see who clicks the button first, and the second person would then get their update returned to them. So it would fail. However, in practice, you don't see failed updates. So that works quite well, and that works better than actually trying to have record locking.
Okay, great, thank you. Nia Roberts has asked, how is the data coded? Does it use SNOMED codes?
It does, yes.
Fantastic, thank you. I'm just going up. Got another one from Ian Haywood. I don't think we've answered this, but it says, how do you deal with clinical systems that do not support native outbound FHIR? Also, which versions of FHIR are you using?
Okay, so one of the early design decisions that was taken for SIDeR was that the owners of each silo of data would actually build their own FHIR interfaces, and they've worked in conjunction with Black Pear to get themselves to the point where they now have FHIR interfaces. There were two reasons for that. The first was that it means that the people providing the mapping have got a deep understanding of the data to make sure it's clinically safe and accurate, and can make decisions that are right for their organisation. And secondly, it means that there is a legacy of the project, meaning that those organisations have now developed expertise in fire, and they've got fire APIs that they can actually utilise, and I believe are doing so, for other projects other than just the shared care record. So it's helped to bootstrap the interoperability across the region as a whole as a byproduct of the care record project. The original interfaces are all Fire SDU3 using Care Connect profiles, and then the interaction patterns taken from Care Connect API. There's an ongoing project where Fire R4 is being adopted. So in parts of the infrastructure, it is now Fire R4. The intent is UK core will be adopted when the ballot's complete, and we'll also have to check that there is an equivalent to Care Connect API to specify the interaction patterns.
Okay, that's great. Thank you. I've got two more questions left. Jason, in fact, another one's just turned up, but Jason Scott's asked, on the topic of integration, does it use any any desktop client software to handle any of the integration?
The only desktop software we've had has been a browser within the GP practices, and we're trying to move away from that by using contextual launch from EMIS. We believe we should eliminate that completely.
Okay, thank you. And the last question is, so this is from Kath Lambert. She says, if the same information is included in multiple forms, e.g. CPR status, does it update all forms if updated in one?
It currently doesn't do that, but we are working so that it does update across all forms. So that is something that's very much in the imminent roadmap.
Fantastic, thank you. And another one's come in from Ian Hayward. Can you share your data sets for both adult and children's social care?
If you email our team email at the end of the slide set, we're happy to discuss that.
Brilliant, thank you. No more questions at the moment.
There was some at the beginning, I think, that I didn't answer. From Ian. About it's probably one for Justin, which is why I didn't answer it. The two-part one.
Okay, yep. So Ian, sorry, yep, I missed that one. So Ian's at the start. Justin, I don't know if you can see it because it's quite a long question. So you might. Oh, you're on mute at the moment.
Yeah, just having a look at it now. Yes, so this is sort of partly historic, and there was a lot of discussion across the system about the fact that there was an aspiration to share this information for the purposes of direct care and how we would do it, and basically there was probably 5 years worth of discussion and looking for money prior to us actually going out to procurement, and actually we used the end of life use case as a case in point, because the previous system just simply wasn't being used because it was so cumbersome, and it took people, we actually did some work, and it took people something like 20 minutes to enter data into all the fields to be able to create a record, and that was transformed into 2 minutes with the black pair system, and we have certainly done a lot of work within our team initially to go out and talk to various teams, for example, community care teams, district nurses. I've been out and talked to them about the benefits of using the EPACS forms, but the challenge is that there are obviously thousands of clinicians out there. So we have produced training materials, flyers, information. I mean, Jess will be able to take you through all the detail of that, but had to rely on the fact that really we would need the stakeholder organisations to do a lot of that sort of engagement. What we actually have found is that when people see the sort of information that we're presenting there, they want to use it as soon as they possibly can. So actually we feel like we're pushing at a bit of an open door. There have been some challenges in some areas such as A&E where they actually, the difficulty is that they don't have, they have limits to the number of devices that they can access around the department, and they're multi-users on any one device. Certainly we haven't had any significant challenge around the non-persistence of the data at the moment. There has been some challenge, and that's why we mentioned that we're trying to do some of the work so that the information that is being presented, I think that would be the next step that we'd want to look at, can be brought into users' native systems for them to create their own care plans relevant to their area of work and involvement with the patient, is probably the best way that I could describe that.
That's great, thank you. That is the end of the questions at the moment.
That's fantastic. Thank you very much. If there are any final questions, do drop them in the chat box. I've just got one in terms of Dorset Care Record. We've kind of struggled a little bit in terms of getting support for children's records to go into the DCR, and I was wondering how you managed to convince the local authorities in Somerset to part with that information.
Well, again, I think we were we were somewhat pushing at an open door, by having discussions with the clinicians. They were keen to share the information, to be honest, and they could see the benefits of making this data set available to us about safeguarding. I think the safeguarding leads were particularly passionate, but also the special educational needs teams were keen to share the information that they've got, particularly with primary care and with secondary care. So I think that was really straightforward. But Jess.
Yeah, and just to say that work was actually been funded by NHS England directly with County Council to do that work. So that was also, I guess, an incentive. But as Justin said, we've had a really good relationship with them from the beginning.
Thank you, that's really helpful. Paul, is there anything else in the chat box?
No, not at the moment, Tony.
Okay, I'm going to say thank you very much indeed to Dr. Justin Harrington and to Jess Brown, but also to Tiff and Dunmail from Black Pear. Thank you so much for all your help and support, and just wish you a great afternoon. Thank you very much.
That's great. Thank you very much, Tony.